CKD, mineral bone disease. CKD, you do not have the conversion of the 125 dihydroxyvitamin D3 or D2 in the, because it is being done with 1 alpha hydroxylase in the proximal tubule. They are less, so they do not have the kidney. These children do not have less appropriate amount of 125 dihydroxyvitamin D. So thereby they have low calcium, low phosphate from the gut absorption and kidney reabsorption. Low calcium incites the hyperparathyroidism, and in the long term you have increased amount of FGF23 elevation from the bones and tooth in the CKD, which in turn causes one-term alpha hydroxylase deficiency and thereby less amount of 125 dihydroxyvitamin D2 or 3. Also, these children do have less amount of sodium phosphate co-transporter, sodium phosphate 2A and 2C. So they have increased amount of phosphate in the urine, phosphaturia. Also, the FGF23 causes decrement of the 25 hydroxylase activity. Increment of 25 hydroxylase activity give rise to the vitamin D inactivation. It turns vitamin 125 vitamin D3 or 2 into an inactive metabolite. So thereby ultimately at the end of everything we have hypocalcemia, hypophosphatemia, and vitamin D, hypervitaminosis D, and hyperparathyroidism. So an increased product of the calcium into phosphate, rachitic bone disease, and calcification in the vascular system, heart and the major vessels and others also affected. So because of the hypophosphatemia and excess phosphate excretion, the less phosphate excretion, these children has the hyperparathyroidism, which causes conversion of the myoblast into osteoblast. So myoblast osteoblast transformation, and the decreased clotho expression. Clotho is a cofactor for FGF23. They have increased amount of calcium and phosphate product, and high dose of calcium and 25 dihydroxyvitamin D3 or 125 dihydroxyvitamin D3 is necessary. So the causes ultimately calciphylaxis and your rachitic presentation. Apart from that, the commonest presentation of the vitamin D, like rosary, rachitic rosary, Harrison sulcus, the widening of the wrist, hypotonia, genu valgum, genu varum, less dentition, delayed dentition, slip capital femoral epiphysis, avascular necrosis of the femoral head, and pathological fractures, all the rachitic changes, growth failure, all are possible. Recurrent chest infection, all are possible. So control of the vitamin D, calcium in CKD patients in the appropriate manner with appropriate dose of the calcium and vitamin D with periodic follow-up, so that neither goes up or goes down, and so it's essential. And food, diet, nutritious CKD nutrition, CKD diet is also essential.